I think we are live. We'll start the
We are
webinar.
live now.
Good afternoon, everybody. I, Dr. Madhura, welcome all of you on behalf of Pune Obstetrics and Gynec Society for our Cutting Edge webinar series. Just a short introduction about the webinar. So this was a brainchild of Dr. Meenu Agarwal ma'am, who needs no introduction. She was the past president of POGS and she is contesting for VP Foxy elections. So we started this webinar a few months ago, where the motive was to have short lecture series for everybody. So we have this every Tuesday, 4 to 5 p.m. with short and crisp topics with practical aspects and more importantly, as the name suggests, cutting edge. So something more than what we normally do. We mostly it is related to hysteroscopy, laparoscopy, infertility, and ultrasound, and we have intrapartum care with it. So I would like to welcome you all for this webinar. Today we are lucky to do it with Faridabad and Bareilly Society. So I welcome the dignitaries on the dais and I request Dr. Meenu Agarwal ma'am to say a few words.
Unmute.
Yes. Hello, everyone. And I'm very sorry. I'm actually just now joined from the phone, but I'm trying to join from my laptop. And I'm very happy to be a part of this cutting edge webinar, which is by Pune Obstetric and Gynecological Society. We have our president, Dr. Aarti Nimkar, and Dr. Meenakshi Deshpande here. And very, very happy to have our guest of honor, Dr. Maninder Ahuja ma'am. Maninder ma'am, I think everybody knows she's a fitness freak. She's a legend of gynecology. And it's always a pleasure to be connecting with her either online or offline. And we have Dr. B. Kalpana with us, who's the chairperson of Infertility Committee of Foxy. Very dynamic chairperson and always having so many good programs one after the other. We also have the Faridabad OBGY Society, Dr. Kiran Chandra with us, and Dr. Chanchal Gupta, the secretary of Faridabad OBGY Society, and Bareilly OBGY Society, Dr. Mridula Sharma is with us, the president, and Dr. Gayatri Singh, the secretary. So thank you very much, Faridabad and Bareilly Society, to associate with us with Pune OBGY Society, as well as Dr. B. Kalpana Madam to associate with us from the Fertility Committee of Foxy. So with this, I think we can go ahead and then we can start the and just for the guest of honor, this cutting edge program, it is every Tuesday 4 to 5, and it's just 2 lectures we keep. Generally, we have one lecture which is either on endoscopy, infertility, or ultrasound, and one lecture which is on obstetric care. So we try to keep everything for the gynecologists, and we have been always having very good attendance, and it has been very well also circulated by the BSV people. So thank you very much. And Madhura, we can take it forward from here.
Yes, ma'am. Thank you so much, ma'am. Now I request Dr. Aarti Nimkar madam, who is the current president of POGS, to say a few words.
Yeah. Meenu madam is already welcomed all the faculties and guest of honor, Dr. Maninder and Dr. Kalpana. And Meenu has started this program, Cutting Edge, and POJ, with the POJs, it become very popular. And I think for years it will go, because somebody will stand for the VP and he will like to continue this because they have to connect with all the faculty. So I wish you the best luck for your vice presidency and candidature, and we will help you in everything, whatever you want. Thank you very much.
Thank you, ma'am. So before we begin our webinar, let us take the blessings of the Almighty. I would request Mr. Prasad to play the prayer song.
Thank you, Aarti madam. And thank you, Amol, Vaishali, Charu, Madhura, also, for every week after week that we are all here. Please go ahead, yes.
I'm the other one.
Thank you. We are today blessed to have such eminent guests of honors with us. Thank you so much for sparing your time. I request Vaishali ma'am to introduce our dear Dr. Maninder Ahuja madam.
Thank you, Madhura. It's indeed a great honor for me to welcome our guest of honor, Dr. Maninder Ahuja, and to give formal introduction of Madam. And on behalf of all of us, we would like to thank all the faculty who are present here today and all the delegates who have logged in. And I take this opportunity to once again to tell everyone that Dr. Meenu Agarwal is going for Vice President Foxy West Zone election. And I request all of you to vote for Dr. Meenu Agarwal because she is not only eminent national, international faculty, but she is truly a great academician and who excels in everything that she does, whether it's endoscopy, ART, imaging, obstetrics, in everything. And Foxy deserves a leader like her. So, coming to my formal introduction regarding Dr. Maninder Ahuja, Madam, I am truly very thankful, and there's huge gratitude in my heart as I talk about you because you are my dearest friend. And I think you are a wonderful and dear friend to each and every Foxian and each and every person who meets you. We are truly showered with your warmth and your love. And we are truly inspired. You know, you're a highly inspiring personality with your fitness, with your dance, and the huge amount of work that you have been doing in Menopause Society later on and earlier as Vice President Foxy. And we all wish you luck, best wishes for your incoming ICOG elections also. So, Madam is an academician who has more than 45 years of work done on holistic health of women. And some highlights of academic journey is she is more than 20 years with Foxy. And she has had many designations. She's a director, Ahuja Hospital and Infertility Center, Vice President Foxy. She's been chairperson Midlife Committee 2009-2011, President of Indian Menopause Society 2014-15, Editor-Chief Journal of Midlife Health. She's Vice President at FOM, South American Association of Menopause Societies, Associate Editor also of the same journal. And she's also founder member of many professional organizations. Madam has been President of Faridabad OBGYN Society, a wonderful society. Really, I have had the honor, pleasure of visiting Faridabad Society and was truly impressed. And Madam, the way you conduct your motto, actions speak better than words. We are truly inspired by everything that you do. You have received many awards. And her hobbies, as you know, are dancing and fitness. So, welcome, ma'am.
Thank you, Vaishali, for those kind words. Do I have to speak? Can I take the mic now?
Yes, ma'am. Please, we would we request you to give us your blessings.
Yes.
And say a few
It
words.
is an honor to be with the Pune Obstetrics and Gynae Society. I was just discussing with Vaishali that Pune Obstetric Gynae Society is one of the best societies of Foxy. It's always in the academics, in the cultural, in the coming forward, in the leadership qualities. I think these are inculcated into the members of FOX. So it's a great organization. And as I always tell all of you that I was born in Pune and my sons were educated in Bharati Vidyapeeth, one MBBS, one the BDS. So I belong more to Pune than out of Pune. So it's always an honor to be here. But today's webinar cutting edge series, which are the mind brain of, I think, Meenu. And with Meenu, I was just recently in Pune again with Vaishali Chavan and all that. So my esteemed thanks to our Pune president, Dr. Aarti, and then Meenakshi Deshpande. And I just heard Meenakshi has cleared her law, I think. Congratulations on that also. And then we have our speaker for the session as Meenu Agarwal, who will be talking on decoding the myomectomy. So myomas are really, I mean, they are born with the woman.
and they go with the woman. So from womb to tomb sort of a thing with the myomas, and you can discuss in any way, anywhere. The talks never end. The new horizons always keep coming up. And I think Meenu will cover on those new horizons. So I'm really thankful and welcoming to Dr. Vaishali Chavan, Dr. Charulata, who are really always the backbone of Pune Obstetrics and Gynae Society. And our Master of Ceremonies, Dr. Amol Lankar. I think he's a very promising young coming. And Dr. Kalpana, who is my co-chairperson, co-guest of honor. And then members from Faridabad Obstetric Gynae Society, which was, I'm the founder member of that Faridabad. And for me, it's always my baby. So that's always there. So Dr. Kiran Chandna and Chanchal, they are from there. And I wish best for Kiran Chandna also, because she's also coming for election for the MTP committee of FOGSI. And then we have our very really wonderful speakers from the Bareilly Society, who have made a complete panel on the intrapartum care. And I think that intrapartum care, a very, very special place always has in the obstetrics gynae practice. So, but now I'll just add one thing, that from this intrapartum care, now the time has come to move to the postpartum care also, and extended postpartum care, not that routine 3rd day and 6 weeks visit, but diagnose the patient who have the adverse pregnancy outcomes, diabetes, hypertension, or any other problems, weight, too much of weight gain or anything, and continue with them for 6 weeks to 2 months, 3 months, 1 year, and even beyond if they need it, because that is the only way to prevent the cardiometabolic diseases later on in the midlife. So whether we have to prevent obesity or hypertension or diabetes, we have to start from intrapartum to postpartum care. So there has to be a continuing of care and no stoppage that we are stopping it here. Women still belongs to us only. So thank you very much again for inviting me here as guest of honor. I'm really honored, and of course we'll need everybody's vote and support, because I think we will be having maximum FICOG members from Pune only. So thank you very much for inviting me again.
Thank you, Maninder ma'am. That was an excellent overview of the program, as well as your thought process on how should we tackle these issues. And thank you for your best wishes. And I know they are coming from the heart. So thank you so much for that. And it's always a pleasure to. In fact, we got connected very well after your visit to Pune. You know, we could see
Yes.
your warmth, your personal attention to everyone. So that was really, really visible on your visit. So thanks for
you.
sparing time to be the guest of honor for this meeting, and wish you all the best.
Thank you. Thank you. Yes.
And I can
Thank
see
you.
Dr. Anita Nath also here. Welcome, madam. Our next speaker on the joyful motherhood.
Thank you so much, ma'am.
Thank
Thank you
you.
so much. Yeah.
Thank you. Yes. So,
Yes, ma'am. So now I request Amol sir to introduce our other guest of honor, Dr. Kalpana madam.
Yeah, good evening, everyone. At the outset, from Pune Obs Gynae Society, I welcome all the faculties and delegates over here, and I thank Infertility Committee FOGSI, Faridabad Obs Gynae Society, and Bareilly Obs Gynae Society for associating with this cutting-edge webinar. Today, it's an honor to have Dr. B. Kalpana as our guest of honor. And we all know her as the chairperson in Fertility Committee FOGSI. She is the course director for the postdoctoral fellowship in endogynecology affiliated to MGR Medical University. She is consultant gynecologist at an infertility consultant at Guru Hospital, co-chairperson for Infertility Committee of Tamil Nadu Obs Gynae Society, vice president of MOX, president of Madurai chapter of ISAR, and organizing secretary of MOX Silver Jubilee Conference 2018. She has to her credit several awards and several publications also. So we welcome Dr. B. Kalpana. And thanks for the Infertility Committee, Foxy, for getting associated with this cutting edge webinar. Madam, for your kind words. Dr. B. Kalpana, madam. I think she has some range issue.
Am I audible now?
Yes.
I'm really sorry. Thank you, Dr. Amal, for your kind introduction. I hope I'm not disturbing you. I'm not in station. And I'm really happy to be a part of this webinar organized by past and present office bearers of Pune OG Society and Breast Committee Chairperson, my dear friends from Pune. It's my pleasure to be part of this because I've done various programs in association with Pune OG Society last year, and it's really a pleasure to be associated with POGS and the topics. We got a wonderful message from our chief guest, Maninder Ahuja, ma'am. Thank you so much, ma'am. And the organizers had selected wonderful topics, debatable topics. Myomectomy, when to do and how to do, and speakers, wonderful speakers. I wish to watch all these, but I'm not very sure how my internet would be, and also I think this would be a wonderful webinar, and delegates will be really benefited from this webinar, and my best wishes to every one of you. I think I'm not disturbing you. Thank you so much.
Thank you, ma'am. Thank you. Thank you for
Yes, not at all disturbance. It's an honor for us to have you, and thank you for taking out time while you are on a holiday or you're visiting somewhere, and still you logged in and you spent that much time. So thank you so much for that.
Yes, ma'am. Thank you so much for your blessings. Let us move ahead with the first session where Dr. Meenu Agarwal ma'am will be talking about decoding myomectomy. I would like to invite our esteemed chairpersons for the first session from Faridabad. I would like to invite the president of Faridabad Society, Dr. Kiran Channa, and the secretary of Faridabad Society, Dr. Chanchal Gupta. I request Meenakshi Deshpande madam, secretary of POGS, to introduce Kiran ma'am.
Yeah, hello, am I audible?
Yes, ma'am.
Yes, okay.
Yes.
So thank you. And we welcome all the faculties of Faridabad Society and other society which is there today with us for the POGS panel discussion of cutting edge webinar. So we welcome Dr. Kiran Chanda, who is the president of Faridabad Obstetrics and Gynecological Society. She is a coordinator of MTP committee of FOXY, and she is the organizing chairperson of MTP Con in 2022. She's also the organizing chairperson of the cadaveric dissection of internal iliac artery workshop in 2023. And she's got many publications in journal and chapters in Foxy Focus. She's also a faculty in many conferences. So she's done Madan, Saral and Jana Jagruta programs of MTP committee. So we welcome you, Dr. Kiran Chanda, to this cutting edge webinar. Welcome.
Thank you, madam.
Thank you.
I would like to introduce our next chairperson, Dr. Chanchal Gupta. She is a senior gynecologist with more than 20 years of experience. She's been handling high-risk obstetric cases and laparoscopy cases. She has been working at Asian Fidelis Multispeciality Hospital, Metro Heart and Multispeciality Hospital, Faridabad. She was a registrar in OBGYN in Indraprasth Apollo Hospitals, New Delhi. She is currently the secretary of Faridabad OBGYN Society. She's a life member of Foxy. She is a city representative for Haryana Association of Registered Obstetricians and Gynecologists. She is an executive member of HIAGE, which is Haryana Society, and she's a life member of Indian Society of Colposcopy and Cervical Pathology. She has special interest in gynec laparoscopies, high-risk pregnancy, and preventive gynec oncology. She has won many awards. She has won a silver medal in the 30th annual conference of AOGD in 2016 and first prize in paper presentation in IFS 2017. I welcome you, ma'am.
Thank you, Dr. Madhura.
So, ma'am, let us start the first session. I request Kiran ma'am to introduce our speaker, Dr. Meenu Agarwal ma'am.
Good afternoon, everyone, and thanks for involving our society as participant in this webinar, Cutting Edge. My pleasure to invite Dr. Meenu Agarwal with lots of best wishes for her in the coming election. She is immediate past president, Pune OBGYN Society, elected Secretary General, Indian Society of Gynecological Endoscopy, FOGSI, Imaging Science Committee Chairperson. She has been Bachelor in Reproductive Endoscopic Surgery, Post Director of Endoscopy.
No, madam, it's all right.
Yes. ARD, many awards to her. She's icon of health by Times Group, inspiring gynecologist of West India, and she's FOGSI champion of FOGSI award. Welcome you, madam. We are happy to listen to you, madam, and gain our knowledge. Over to madam.
Yeah. One moment. Why I'm not able to share my screen? Okay. All right. Are you able to see my slides?
Yes, ma'am. Yes.
Okay, fine. So, first of all, once again, thank you Faridabad OBGYN Society, Bareilly OBGYN Society, and Infertility Committee of FOGSI, and thank you Dr. Chanchal Gupta madam and Dr. Kiran Chandna madam for chairing the session and for the kind introduction. Since it is more with since we are associating with Fertility Society, I thought I will keep my talk also a part of it associating with fertility. So when we talk about fibroids, I shall be slightly touching upon what is the current evidence कि कौन से fibroids निकालने हैं, कौन से नहीं निकालने हैं, whether to go for laparoscopic myomectomy or to go for a hysteroscopic myomectomy. And we understand that although the fibroids may occur in 30% of reproductive age group women, all of them do not cause infertility or any symptom. They may be asymptomatic. However, some fibroids may cause infertility by obstructing the tubes or by impairing the transport of the sperms or the eggs. So let us look at this first case. She's a 26 years old lady. She has primary infertility for 2 years. Her husband's semen analysis is normal. Ovarian reserve, ovarian function, everything is fine. HSG is showing bilateral tubes are patent and there is a suspicion of 1 centimeter submucosal fibroid. So this is the case scenario with us, and now let us see what we should do. Now when we look at the guidelines, what do the guidelines tell us? That in women where we have a cavity distorting myoma, like a submucosal myoma, so those are the cases we must consider removing these fibroids to improve the pregnancy rate. So it can be, if it is a large fibroid, it can be open, laparoscopic or hysteroscopic. So these are the fibroid that they should be removed. So this patient should go for a myomectomy when we look at the guidelines. Now we can go for a hysteroscopic myomectomy, or we can go for a in this particular case, since it is a 1 centimeter small fibroid, a hysteroscopic myomectomy is the right way to go. Now, suppose it is a FIGO 0 fibroid, then it's quite simple to do it. We should use a bipolar now. Whoever is going for new resectoscope, it is much safer, and you can use normal saline and bipolar. Always keep the loop under vision, and if you find a bleeder, do not increase the pressure to stop the bleeder. Okay, you can increase the pressure and then slightly reduce the pressure, find the bleeder, coagulate the bleeder, and then go ahead. Otherwise, the fluid will keep on going into the open channels if you have just increased the pressure, and then we can have a problem. Another thing we should keep in mind is when we suppose we are coming out in between to remove all the bits and pieces floating inside the uterine cavity. Make sure you close the cervix, close the perineum. Just tell the nurse to take a mop and keep it on the vulva, so that there is no air going in. So there were a recent, I think, 3 patients which were in IAG, which were reported that there was an air embolism, and it is very, very, very important, especially in these patients, to take preventive measures so that these complications do not occur. If we have the facility to use any kind of a tissue retrieval system, this is a Bugatti shaver, excellent instrument to equipment to have with you, and it is especially for infertility patients. There is no current, no coagulation. It is a mechanical and electrical energy which is converted to mechanical energy, and very beautifully you can just cut and suck it. I mean, 5 minutes is an overstatement for a 1 centimeter fibroid. It's very quick, and now we are also doing it as a office procedure. Then sometimes we may land up with a case where the fibroid is not FIGO 0 or FIGO 1, it is FIGO 2, but patient is in a hurry to go for her fertility treatment, and those are the patients where there are many publications now to show that we can give a small incision exactly around the fibroid and even leave it, and then the fibroid, and give a small vertical incisions on the fibroid, leave it, and they would pop out as FIGO 0 or FIGO 1, and can be tackled at a second stage. Or if you want to do it at the same time, we can probably use a little bit skill, more skill is required, but we can use a myoma screw and gently pull it into the cavity, make it FIGO 0 or FIGO 1, and then use. उसको ज़्यादा नहीं pull करना है, अगर ज़्यादा pull करेंगे तो it will break. So that thing we have to keep in mind. When the myoma screw will break, and then you will also have a challenge to remove that small piece of myoma screw which is got stuck into the fibroid. So we have had all these problems, so that is why you should learn from our problems. So this is another patient, and she is 33-year-old. The husband has oligoasthenoteratospermia, and tubes are patent. There is no problem, and she has a 4 centimeters intramural fibroid. Should we remove? Now, obviously, she's going for ICSI. Should we remove the fibroid? How do we need to counsel this particular patient? Little bit challenging, because we are not very, very sure. So what do the guidelines, that evidence tell us? The evidence tell us that uh, intramural fibroids, you see here, intramural fibroids appear to decrease fertility, but the result of therapy are unclear. So this is a systematic review, and so we need more studies. However, it does reduce the fertility, so we need to counsel the patient accordingly, and maybe at the moment don't touch the fibroid. But if we have already transferred the embryos, either she does not conceive or she has a pregnancy loss. So that is another indication. If suppose you get a patient who has two pregnancy losses, or who had IVF and pregnancy losses, and she has an intramural fibroid lying, so those are the patients, because intramural fibroid can cause a pregnancy loss. So that has to be counseled to the patient when we are planning this counseling for these patients. This is the third case where you can see here she's a 37-year-old lady, 2 years infertility, everything seems to be fine, but she has a bilateral tubal block and she has a asymptomatic, she does not have any menorrhagia, but she has a 4 centimeters intramural fibroid which is impinging onto the cavity. So let us see what do the guidelines tell us. And the guidelines tell us that whenever we have uh, patients where the cavity is distorted, so those are the patients which should go for a myomectomy, so that will improve the pregnancy rates. Few things we have to keep in mind in these patients. One is, don't pull on the fibroid too much. So if your assistant is very aggressive and very proactive, sometimes he or she may pull on the fibroid too much, and that is one of the reasons why we can open the cavity. However, even if the cavity is open, no problem, but we can put methylene blue from down to see that the cavity is open, and go make sure that we go very very close to the fibroid. So this is where we should be cutting, this is where we should be cutting. So that is again very important. And there are few now recent guidelines which I was going through, where in fact I used it for a couple of one of my patient last week, where we accidentally opened the cavity, that take Surgicel and push it so into where you have opened the cavity, so that will reduce the adhesions in the intrauterine adhesions when patient is actually trying to conceive. So we used a Surgicel and we pushed the endometrium with the small piece of Surgicel, and then we went ahead and we sutured, though it was just one case, but this is what we did in our last patient. So we know that Professor Kurt Sem reported the first laparoscopic myomectomy in 1979, and at that point of time, this particular thing was received with so much of criticism that they even said that he should do an MRI of his brain to check that he is not having some mental problem. How can you do a myomectomy laparoscopically? But he went against everyone, and today here we are, and we are talking about laparoscopic myomectomy, and everybody is now agreed that this is the way to go, especially patients with infertility, and we will have less adhesions, less post-operative comfort, better surgical recovery of the patient. So this is what we are using here. You can see this is the primary port. Depends how big is the uterus, how big is the fibroid. This is the first secondary port, 2 centimeter medial and superior to the anterior superior iliac spine. And this is the second port, secondary port, which you can also go here. So this is also a good place, especially when you are going to suture here. Especially for TLH, if you are going to suture here, this makes a good arc. But for a myomectomy, I find this particular placement much better. Very important to make sure that we are not dealing with any malignancy. A good mapping of the fibroid again is very very important. Telling the patient that I'm going to take out this fibroid, this is not bothering you, these two are not bothering you, so I am going to leave them behind. So she should not come after 6 months saying that, doc, you left my 3 fibroids, and you did not do a good job on me. So again, how to reduce the blood loss, that is a very very important thing. So vasopressin, I think all of us are using vasopressin. It is giving us good results. So and getting the good correct plane, again, that is very very important. Even if you go through a little bit into the fibroid, does not matter, but getting a good plane is very important. Sometimes we especially not in patients of infertility, because Dr. Kiran has done, I when they were reading the CV about the internal artery ligation. So we can also do a clipping of the uterine artery, especially in cases where we are finding large fibroids sitting at a very odd place. So those are the patients we can actually also go in for the clipping. Or Dr. Sanket Pisad has very nicely introduced that tape, the knot, the shoelace knot, that can also be done. So this is the retroperitoneal dissection. This is how we are. And this patient was actually for myomectomy for menorrhagia, and she was not keen for pregnancy. So these are the patients we can also go in for the ligation, and that is a possibility. And the blood loss becomes very, very less. So it's a cervical fibroid. So once you have done that, then it becomes very easy to go ahead and operate on these patients. Another small tip, that whenever we are dealing with fibroid at an odd place, now this is at near the corneal end, then rather, and very irregular fibroid, teda medasa fibroid, not round fibroid, then use of this tenaculum. I find this tenaculum is a very, very versatile instrument, should always be on the table, and especially for fibroids at an odd position, different size, not that round, typical round fibroid. So this is a very, very good instrument to have, and we can go ahead and sometimes the myoma screw jata hi nahi andar, it keeps on just going through and through. Then use this particular tenaculum, and it helps. Now, what are the suturing techniques? Suturing, same as open. We can go for multiple layer closure. We can go for single layer closure if it is not very deep. What we are using at our center, we are using V-lock. These are unidirectional monofilament with the needle on one end. So this is how the needle first goes through the loop. Okay, all right. So this is the workshop that we were doing. So you can see here. So only the first stitch, the needle goes through the knot, and once that is taken, after that, then it is like a continuous suture, and then we just go continuously and we close it. So that is how it is done. I think whoever thought of the barb suture, मतलब उसके दिमाग में भी ये idea आया कि धागे के ऊपर हम barbs लगा देंगे and it will stay there. I think this idea is so fantastic, and it has brought happiness not only for the patient in terms of a good scar, but also for the surgeons, because it is much faster, and you get very confident. It is a very, it gives you a lot of confidence and security that you have sutured the scar very well. So it is like a continuous interrupted suture, and it self anchors. मतलब जहां पर हमने स्टिच लिया वहीं पर वो स्टिच टाइट हो जाता है. सो इट डज नॉट डिपेंड ऑन द नॉट. नहीं तो नॉट के ऊपर एक अलग स्ट्रेंथ है, एंड आफ्टर 2 or 3 continuous suture the strength is different. So it is like a continuous interrupted suture. The suturing time is much less, and bleeding is also much less with uh, barb suture. And knots, I think knots, this is now the time has come when a lot of people are talking that there should be knotless stitching. Even for open surgeries they're talking about that it should be knotless suturing, because the weakest point, weakest spot in any surgical suturing is the knot. So and also knots can slip, and they can be very tight, they can be very loose. So all these things can be there, though we have not reached that point, but there are people talking about knotless suturing completely. Sometimes we may have a large adenomyotic uterus, so those patients also may have infertility, or may have menorrhagia, dysmenorrhea, dyspareunia, and do not want to let go of the uterus. So, so those patients also we can do a conservative surgery with the help of barb suture. Now, as I said, that barb suture has made our life very easy. So earlier we could do it, but the main problem was when they would get pregnant, the suture could give away because the scar strength was not optimal. So now two things we are doing. One is, of course, using the barb suture, and second is we are suturing with flap. तो जैसे ऐसा खोला उसको, तो one flap, the tip, the front, this portion goes down, and like we'd have a wrap dress, and the other portion goes above that. So that is how it is done. So that is how it is sutured. But the only thing is, even though the uterus is very large, sometimes the cavity can be very, very close. Okay, तो आपने dilator भी डाला है, आप इसको कट कर रहे हो, तो we should not go very deep. So we can open the cavity. There is always a small risk of opening the cavity. So that should be kept in mind. Another thing what we can do is we can first put methylene blue. वो नीचे से डाल के रखते हैं कैनुला, methylene blue push करते रहते हैं, so that if you are close to the cavity, you know that you are close to the cavity and you do not want to open the cavity in these patients. So this is about myomectomy and some patients of adenomyoma. We have to keep another thing what we can do in patients of hysteroscopic myomectomy, how to reduce the blood flow. One is to use GnRH agonist. So how to use it? So 3.75 every month वो देने के बाद, and then go for the hysteroscopic myomectomy. The blood loss is much less and the size becomes smaller of the fibroid. So that is again a good thing. Second thing is the AGL guidelines tell us that you take diluted vasopressin शुरू करने से पहले, before you start the dilatation, to put the resectoscope, and that is injected at not at 3 and 9, so you can take 2 and 8 o'clock position. So this vasopressin injection will reduce the bleeding at the time of myomectomy, and also it will slightly help in the dilatation. So these are the few things which are the guidelines by the AGL for hysteroscopic myomectomy. So I think the video is somehow is got frozen over here. So just some take home points. Only the submucosal and fibroids which are impinging onto the uterine cavity should be removed. Intramural fibroids not very clear, and subserosal fibroids should not be removed. Then for sometimes we do morcellation in the bag. The only advantage I find of doing it in the bag is that whatever is, छोटे छोटे pieces गिर जाते हैं, so they fall in the bag and it becomes very easy to do it. This was our one case which we actually published. This was a case of myomectomy scar ectopic, and we treated it just like a corneal ectopic. So we took a purse string suture all around and then opened it, and this was you can see the membranes bulging, and then we closed it with barb suture. So this was I think 2017 we published this particular case. This was actually the first case laparoscopic myomectomy. Usse pehle one was subserosal and one was with methotrexate. And in the same year there was another publication by PG Paul sir on the same case. So how many fibroids to be removed does not matter at all. I think now we are doing so many myomectomy. There are so many videos which are there. So I think we can just skip that. And now they have also come out. What is this, if anybody can tell me? This is an ultrasound probe in the laparoscopic instrument. So we can put this intraperitoneally during the surgery and look for some people are taking pancreatic biopsy, liver biopsy, to look for the area from where to take the biopsy, and also can be used to pick up any small fibroid which we might leave behind if we don't know, if we miss that out. So do not do laparoscopic myomectomy prematurely. For my juniors friends here, always, even TLH is easier than laparoscopic myomectomy. So take your time, always go for the smaller fibroids in the beginning, less than 6 centimeter, and initially go for cases where there is simple cases, no previous surgery done, single fibroid, preferably fundal fibroid or posterior wall fibroid. They are easier to suture. So thank you very much, and if there are any questions we can take it, otherwise we can go for the next lecture. Thank you so much.
Thank you, Minu madam. Excellent lecture. Thanks a lot.
Thank you.
Madhura?
Thank you, ma'am, for such a wonderful presentation. Thank you so much. You cleared so many points, and there was so many take-home messages. Madam.
Thank you, madam. Thank you, Kiran ma'am.
Thank you, Meenu ma'am, for a wonderful lecture. And really, you have very much cleared the points to which fibroids to be managed hysteroscopically, which fibroids to be managed laparoscopically, and should not just jump on removing all the fibroids which are not to be removed. And the PAP suture has made our lives easier. I don't know how much it benefits the patient, but definitely it is a good hemostatic suture, and it makes our life easier when it's a big fibroid and you have a very big myoma bed to close where you need at least a 45 centimeters of suture, and you need at least 2 or 3 when you are closing in layers. Thank you, ma'am. Wonderful.
Yes. Thank you so much. Thank you.
Thank you, ma'am. Let's move to the next session, where I would like to invite Dr. Anita Nath madam from Bareilly to give her talk. I would like to invite our esteemed chairpersons for the next session, Dr. Mridula Sharma and Dr. Gayatri Singh. I request Amol sir to introduce Dr. Mridula Sharma.
Yes, good evening, everyone. And at the outset, let me thank the Bareilly Obs-Gynae Society to get associated with this webinar. And we have the president of Bareilly Obs-Gynae Society, Dr. Mridula Sharma, chairing this session today. She has organized the 35th annual UP annual conference at Bareilly in April 2024. The director of Dharma Datta City Hospital at Bareilly, alumni of the prestigious Lady Hardinge Medical College, New Delhi, and formerly at Safdarjung. She is actively involved in the Manyata Foxy, and also she was the member of the Safe Motherhood Committee, Foxy 2020-2023. She is recipient of the Foxy Appreciation Award 2023 and recipient of the President's Appreciation Award Foxy 2019. Organizing secretary for the UP midterm annual conference and delivered talks at various forums. She has a keen interest in adolescent health and in obstetrics. So thank you, madam, for chairing this session, and welcome to Dr. Mridula Sharma.
Thanks a lot. Thanks a lot for having me here.
I would like to introduce the next chairperson, Dr. Gayatri Singh. She's been working at Mahendra Gayatri Hospital, Bareilly. She's currently the secretary of Bareilly Obs and Gynae Society. She's presented papers in Yuva Foxy North Zone, and her special interest is in ultrasound and high-risk pregnancy. Thank you, ma'am, for joining us. I welcome you.
Thank you. Thank you so much.
So I hand over to the chairpersons to conduct the session. I request Dr. Gayatri Singh, ma'am, to introduce the speaker.
So I invite Dr. Anita Nath. She is the Dynamic Clinical Secretary of Bareilly Obs and Gynae Society. And she is the owner of Nath Hospital and practicing for last 25 years. And she's a state champion in table tennis, and her special hobby is table tennis, and she's a champion. At present, she is the Clinical Secretary of Bareilly Obs and Gynae Society. So welcome, Dr. Anita.
Thank you so much, Dr. Gayatri. So let's start with the session, right? Respected seniors and dear colleagues and friends, and it's really a pleasure to be associated with Pune Obs and Gynae Society, and especially with this such a good series, fantastic series of cutting edge webinar. So today's topic is let's discuss about the programmed labor pain. See, as an obstetrician, we all strive to provide optimal care for the patient who is undergoing the labor pain. And so it's essential to re-examine our approach to management. So let's explore the latest insight through case study. And beauty of this study is it's done in India, and it's by our very own Dr. Shirish and Daftari, Dr. Shyam V. Desai, Dr. Uday Thanewale, Dr. Amarnath Bide, Dr. Jesse Levy, Dr. Amit Patki, Dr. Narendra Mehrotra, and that too in the labor room of Nauroji Wadia Maternity Home, Mumbai. So we'll discuss today. We have a discussion in the case study, case control study. We'll see how we have benefited in programmed labor and how it is different from the control. So I'll go through the slides. I'll just share the slides. Just a minute, I'll take just a minute to share this. Fine. इसमें नहीं ना ना share. Sorry. दोबारा करो share documents. इसमें रखो नहीं था प्रोग्राम लेबर आएगा इसमें अभिषेक से पूछो कि प्रोग्राम लेबर मैं डॉक्यूमेंट शेयर नहीं कर Can somebody share the document?
The slide you are saying, ma'am, I can share.
Yeah, document. I don't know where I saved.
Dr. Amol, can you share your screen? Dr. Anita?
Ma'am, is this
I'm not able to
slide you're
share
saying?
my screen.
Yeah.
Yes, yes.
So
now
I
it
think Dr. Amol, can you share it?
Yeah, now we can see it just
Yeah.
for the full slide,
Yeah, I'm not
slide.
laptop computer savvy, so not able to
Is
just
is
present
this
the
your
slide.
screen,
Yes,
Dr.
this is the
Anita?
same.
Yeah, just back ho jao, back karo.
Now we can see it, madam.
Nee, nee.
Anita, madam.
This is this is
Yeah.
shared
Are
by
you
this
sharing
is shared by BSV, ma'am.
This is not Dr. Anita's screen.
Yeah,
No,
this
no,
is
this is
This
not
is
my screen.
shared by
That
Mr.
one,
Prasad,
yeah.
but same PPT hai.
Yeah, but I think we can continue with this.
Yeah, we can continue with this. So, today's topic is intrapartum care for the joyful motherhood. Next, please. So, intrapartum care is the concept based on 3 pillars: providing optimum pain relief, that is by the use of analgesic and antispasmodic, ensuring adequate uterine contraction, that is the active management of labor, and third, close monitoring of the labor, maintaining a partogram. So active management of labor concept was given way back in 1973 in Irish school by Driscoll and the colleagues, and that reported the advantage, gave the advantage of management of active management of labor, resulting into shorter labor, improved obstetric outcome, and lower cesarean sections. So here, motto, why we are so concerned about managing the active labor pain? Because our aim is to prevent infection, dehydration, ketosis, exhaustion, disillusion in mother, and fetal distress. So this is the partogram which we are going to discuss later on also. This is a simple piece of paper that includes so many things. That is all labor events, right from the cervical dilatation with the time to fetal heart rate to uterine contraction, drugs given, whether membrane is intact or ruptured. So we can discuss this later also. It will come in the next slides also. So here we have to select few patients, like we can't take all patient in study group. So patient selection is patient should not have any identifiable medical or obstetric complication. Patient should be primary gravida with singleton pregnancy with cephalic presentation and spontaneous onset of labor. So here we are not going to take the induced labor. Induction वाले patient को हम नहीं लेते हैं. Spontaneous labor we take. Gestational maturity should be in between 37 to 41 weeks. At the time of admission, anesthesia should be reactive. And the foremost thing that here we monitor the active phase of labor, which starts with the cervical dilatation 4 centimeter and effacement 50%. Patient selection criteria should be primary or multi, but more than 38 weeks. Patient should be of low risk. Presence of anesthetist and neonatologist be present. Patient should be taken, and patient in active labor phase, active labor pain, that is 4 centimeter or more. Patients not to be considered are high-risk cases like antepartum hemorrhage, preeclampsia, diabetes, polyhydramnios, oligohydramnios. CPD should not be in suspicion, malpresentation, and pre-labor rupture of membrane. These all patients we are not taking in our study. So here aim is, first is to minimize pain and second is to monitor. And in this series, when we think of medication, what medication protocol intrapartum care begins when patient enters in active phase of labor. So, so starting point of active phase of labor is identified on the basis of clinical evaluation, which is following parameters should be satisfied. Then only we consider that patient is in active labor. Otherwise, we think it's in latent period, latent phase. So cervical dilatation should be 4 centimeter or more, with the effacement more than 50%. Uterine contractions should come at least 3 contractions per 10 minutes, which should last for 35 to 45 seconds. Head should be engaged. There should not suspicion of CPD, and patient may have show or draining, that is leaking. Medication used in intrapartum care as per protocol. See, here we give some protocol. And what is the use of giving protocol? Not a single drug, because here we give labor analgesia and some antispasmodic drug, which softens the cervix and that yielding into dilatation to moderate driving force. Advantages of protocol is least medicine and more effect and less of the side effect. So intrapartum care, here we start with the when patient comes in 4 centimeter or more dilated with the 50% effacement and having good contractions. Minimum contraction, 3 contractions per 10 minutes which lasts for 35 to 45 minutes. So patient we have taken, and now what we start is we just put her on 5% ringer lactate solution. Ensure that pain should be good, that is 3 to 4 sustained pain per 10 minutes. If pain is less than that, then we can add 2 units of oxytocin in drip or tablet pramipros orally every hour. Now, here we give analgesia in the form of, we dilute 30 mg of pentajocin, that is 1 ampule of fortpin, in diluent, and 1 ampule of Campos, that is diazepam. We administered 1/5 of each drug, that is 6 milligram of pentajocin and 2 milligram of diazepam, slowly in bolus form. Start. Next, please. Yeah. And then we observe labor pain by charting maternal fetal parameters, which is very important, every hour. And if necessary, we can monitor it earlier also, half an hour early also. And that is how we assess the progress of labor on the basis of cervical dilatation, descent of fetal head, documented periodically on partogram. When patient is in advanced labor, that is fetal head is pressing down the pelvic floor, patient starts complaining severe pain. That is that bearing down sensation. This time cervix is almost 6 to 8 centimeter dilated, and this is the best time to give ketamine if required. Now, anesthesia during labor. The proven obstetric analgesia is epidural anesthesia. But see, everywhere in the rural, we cannot give the epidural analgesia during labor, because that will need the frequent visit of anesthetist. So it can be replaced by tramadol also. And ketamine is very good dissociative anesthetic agent that gains popularity because excellent pain relief and patient satisfaction. So we grade the level of analgesia in 3 grades. 0, no pain relief. 1, mild pain relief. 2, moderate pain relief. And 3, excellent pain relief. Yeah, so everything is done. Now we start comparing the case study group with the control, so that we come to know how programmed labor is better than the normal one, that is controlled one. So here 200 patients were taken, and for the uncontrolled, then it's seen that vaginal delivery was 88% in study group and 81% in control group. Unassisted vaginal delivery was 121, whereas in control it was just 120. Low forceps assistance was less in study group, 14, whereas in control it was 18. Like that, Ventouse is little more, 31, and control 24. LSCS rate was less, 24%, than the control group, which was 30%. Mean duration of labor, active labor phase was 3.5 hours in the programmed labor pain, and it was 5.2 hours in control group. Mean rate of cervical dilatation was very good, that is 2.5 centimeter per hour in study group, whereas in control it was 1.2 centimeter per hour. Mean duration of second stage of labor was 26 minutes and 48 minutes in control. Mean duration of third stage of labor was 3.5 minutes, that of control it was 15 minutes, which matters a lot because lesser the third stage of labor, lesser the blood loss. And pain relief was definitely good in the study group because here we have given the analgesia, and nil in the control group. Next, please. So again, repeating same case में जो जिसमें हमने एनाल्जेसिया दिया और उसमें 1.2 centimeter per hour cervical dilatation था, whereas in the control group it was 1.3 centimeter, and all three stages of labor were less in the study group. That is, first stage of labor was 3.45 centimeter, second was 27, and third was 4.46 minutes, whereas in control it was first stage was 4.78 hours, second was 34 minutes, and third was 4.45 minutes. Pain relief was definitely more in the study group, and complication was little more in the study group, like tachycardia, like some complication, nausea, vomiting, and then cervical tear was little more in the study group. Still, we consider the active management of labor because the side effects were lesser and that they get subside by the 12 hours. So result is rate of cervical dilatation was more, 1.72 centimeters per hour in case, whereas 1.23 centimeter per hour in control. Duration of active labor was significantly reduced, 3.45 hours in cases, whereas 4.78 hours in control. Duration of second stage of labor was 27 minutes, whereas in control is for 34 minutes. Majority of both patients deliver vaginally. 86% of patients had pain relief as compared to 22% in control group. The case had significantly more drug-related side effect in the study group, which subsided after 12 hours. So when we weigh as a side effects, which can be easily overcome, so always programmed labor was found benefited for the patient who is in labor. There was no significant fetal or neonatal complications in either. So antispasmodic, here the funnel plot comparison of antispasmodic versus control. जब हम antispasmodic देते हैं, so that reduces the first stage of labor by 74 minutes. Yeah. Next, please. Same comparison done, which I think we have discussed 2-3 times, कि कैसे first stage कितना कम होता है, second and third stage. यहाँ पे हम एपिडोसिन के बारे में बात करते हैं, वेलिथामेट bromide, which is known as epidocin and very frequently used by all of us. So, single dose of 16 milligram velethamide bromide was administered via intravenous route, randomly selected 35 nulliparas and 37 multiparas. The median time to complete cervical dilatation to delivery was 20 minutes in study group. That is we are talking about second stage of labor, whereas in control, it was 25 minutes. Next. Yeah. So mean time for complete cervical dilatation to delivery was 20 minutes in groups who received velethamide bromide and 25 minutes in the group who did not. So velethamide bromide is, significantly shortens the second stage of labor. Just now we talked about nulliparous women in nulliparous. Again, side effect the person, the lady who did not receive Velethamide and receiving Velethamide, here side effect was more in flush and fever, which was seen, and nausea, vomiting. These three side effects were more in the patient who received Epidocin. Again, same side effect being compared. I think we discussed so. So while giving rotavirine hydrochloride versus Velethamide, we compare again. So headache was more in group A, which was rotavirine, and less in group B, which was Epidocin. And cervical tear was again group A, that is rotavirine में ज़्यादा था और Epidocin में कम था. तो इतना हमने सब कुछ कर लिया. अब हमारे पास की पॉइंट ये है कि why, how it is, what are the advantages और क्या क्या advantages हैं. सबसे पहले है कि shorter labor with substantial pain relief, significant amnesia of painful events of labor. Average blood loss was less because third stage of labor में भी काफी फर्क है. And then duration of all three stages of labor was markedly reduced. Obstetric management was simplified and lowering of the incidence of operative deliveries. Neonatal morbidity was similar to the control. यहाँ पे cesarean rate भी कम इसलिए हो जाता है क्योंकि we get sometimes unnecessary pressure from the attendant when it is prolonged labor pain, and patient shouts, hyperventilates, extra muscle activity ज़्यादा होती है, then साथ वाले होते हैं वो बहुत कहते हैं cesarean कर दीजिए, so unnecessary intervention भी हमारा रुक जाता है इससे. और पेशेंट को डिसइल्यूजन नहीं होता है जब ये सेकंड प्रेगनेंसी में होते हैं, तो स्विच में नाइटमेयर्स नहीं होते इस प्रेगनेंसी में मुझे इतना हुआ so that I won't conceive next time. So this is how we get advantage, and this comes under utmost care of the patient who is in labor. I think it's done. Thank you so much for the patient hearing.
Thank you, Dr.
Excellent.
Anita.
Very nice talk.
Yes. Thank you, Dr. Anita, for such a wonderful talk, though it is basics. And as Maninder Madam said very nicely, that we have been practicing this since years. But then these need to be reinforced again and again, especially the junior lot who are coming in, so that we can have we can have an intrapartum care for a very joyful motherhood. Very apt title for the talk has been given, and very beautifully covered by Dr. Anita, all aspects of it, the active management of labor, how we need to have a supportive environment, how we need to have a continuous monitoring, what is the rationale of looking after the pain, how we can take care of the pain. Every aspect is very, very important. The positioning, the mobility, the hydration, the nutrition, how we can give emotional support, what are the interventions and the informed consent. Everything is very, very important. And you explained it very nicely. It was an exhaustive talk. Thank you so much. And I would like to thank the Pune Society for involving Bareilly Obs and Gynae Society, and me particularly. I would like to extend my thanks and best wishes to Dr. Meenu for the forthcoming elections, and to Dr.
Maninder Madam.
No, the elections. The Faridabad president.
Dr. Madhuri.
No, Faridabad madam है, उनका भी elections है ना. Kiran, Dr. Kiran. Yeah. My apologies.
Elections में हूँ, she doesn't see.
Dr. Madhura.
Elections, but I am also going to ICOG elections.
Ma'am, Dr. Kiran भी उनका भी elections है. और Maninder madam, yes.
हमारे यहाँ Kiran ma'am is coming for the chairpersonship of MTP committee.
जी ma'am.
I am not coming. I am coming for ICOG vice chairperson elect. So that
जी ma'am.
not already.
Arey ma'am, Bareilly Society loves you, and you haven't been here for a long time. And we keep talking and we keep remembering you. Me, Dr. Neera Agarwal, we are all talking about you. आप आए थे, and we can't forget you in your red sari and looking so vibrant and so beautiful. So we still remember. और आपका due है यहाँ आना.
Sure.
हमारे बरेली में. We missed you in the UPCOG here at Bareilly. जी मैम, हम लोगों ने organize किया था, but आप somehow you couldn't join. And I would thank everyone here, Dr. Meenu, Dr. Meenakshi, and Dr. Amol, and especially Dr. Madhura, जिनसे मेरी बात होती रहती थी, and she used to, she was very kind enough to keep passing on all the information to me. That was very nice of her. And Bareilly Obs and Gynae Society is indeed very, very happy to be associated with Pune and with this series. Thanks a lot.
Yeah, thank you, Mridula madam.
Bye. Bye. And regards to everyone. Thank you, ma'am.
Dr. Anisa, it was a wonderful talk.
Thank you, Dr. Gayatri. बस मेरा शेयर नहीं हो रहा था and
डॉक्टर मीनू जब टॉक दे रहे थे तो मैं वो जो केस स्टडी कर रहे थे ना, वो मैं उसकी सबकी फोटो क्लिक कर रही थी. फिर मैं अब जो ना, I will put it